Thank you for coming. It's the last kind of session of a long meeting. I missed about half of it. I came late, so it was less time for me. So we'll talk this session for about 25 minutes about insect sting allergy. You all have seen it. It's a relatively common condition. We all see it. But I'll try to put kind of summarize some of the ideas about the pathogenesis of the condition and also the treatments. So insect sting allergy is really primary reactions to Hymenoptera. So there are different kinds of Hymenoptera, and we'll talk about it later on. It affects a significant part of the population. There are different studies. The numbers are not very accurate between studies. There are big differences. But it's also a very common kind of occupational disease. So in beekeepers, a significant number, up to 40% of beekeepers, develop severe reactions from being stung by bees. It has a high impact on quality of life. It causes life-threatening reactions, so it causes anaphylaxis in certain percent of these people. And appropriate diagnosis and treatment is very important, as we all know. So these are the different Hymenoptera that we talk about. So they are the bees, honeybee and bumblebee. They are the vespids. And there are a few different categories of the vespids. And these can vary also depending on where you work. So they're different in North America, where I work. There is different in Europe, and there might be some differences also in this part of the world. I'm not sure about that. And also about ants, and I will not talk much about ants, but the second talk today, it's about it's about allergy to some ants, that I guess it happens in this part of the world. So just very quickly about how allergic sensitization works. It's a very general kind of scheme that I will try to talk about. So somebody gets a bee sting, so the antigen is picked up by Langerhans cells in the skin, if it's in the epidermis, or antigen-presenting cells, the dendritic cells in the dermis. It's presented to T cells, and that's how we develop Th2 cells. And these are the classic cells that we see in all kinds of allergy, and it's the same thing also in bee sting allergy. These cells release different cytokines. These cytokines activate the B cells to generate IgE. And this IgE binds to the mast cells, and when in the re-exposure to an allergen, our mast cells these antigens, they are activated, release histamine and a lot of other mediators, and how a lot of the symptoms of anaphylaxis happen or other allergic reactions happen. So in general, our immune system has a decision to make when it sees something like a venom to an insect venom. It can develop allergy. In some cases, we have non-detectable immune response. And what that means usually is that we develop a small number of Th2 cells, of CD4 Th2 cells, so cells that could mediate allergy, but not enough for symptoms, and could generate also a tolerogenic response. And earlier today, in the section about the hygiene hypothesis, there was some discussion about the different T regulatory cells and how these can affect the immune response. So T regulatory cells can have a lot of effects. They can downregulate the effects of both Th1 and Th2 cells, so they can downregulate the effects of the cells that cause allergy. They can suppress also IgE production, and they can facilitate the generation of IgG, that is the type of antibody that it's kind of associated often with immunotherapy that we know about, and also with protective responses. But also can have also direct effects on the effector cells. So the Treg cells can also downregulate the effect of a lot of the effector cells. Natural stings and occupational exposure can do the same thing. So a lot of the people that work with bees actually become tolerant themselves through development of Tregs through the exposure to this venom. And there has been some really elegant work, probably the best work in human system, trying to identify how this immune system has developed through studies on beekeepers, mostly in Switzerland. So what are the types of reaction that we develop to insect stings? So there is a normal reaction. Everybody has an immediate, local, transient reaction, mostly with pain, swelling, inflammation. Then we have large local reaction when we start talking about things that an allergist might see. More late, prolonged, progressive reactions. We have the systemic reactions, and then we can have also other reactions like toxic and serum sickness reactions that I will not talk much about those today. We'll focus more on the large, local, and the systemic reactions. So that's local is a swelling that is big, about more than 10 centimeters, and lasts at least 24 hours. Systemic reactions are the classic Ig-mediated reactions that we talk about, and they can involve a lot of organ system, so skin, GI tract, respiratory, cardiovascular system. And in children, a majority of these systemic reactions are mild and restricted to the skin, although obviously children also can get anaphylaxis and severe reactions to bee stings. But in adults, they are more common to get severe reactions when they are stung with bees. Again, the prevalence of this condition is not very clear, not very accurate numbers. So some studies where they kind of identified self-reported people with severe reactions to bee stings give prevalence from 0.3 to 7.5%. So quite wide range, less frequent in kids. And the incidence obviously of the most severe reaction, when we have mortality from the reaction, is much lower. So about 0.03 to 0.48 fatalities per million inhabitants per year. So it's quite rare, but still it's a significant problem. Actually, if we take it as a cause of anaphylaxis, in adults it's the second after drug allergy. So in adults it's much more common to get anaphylaxis from bee sting than get anaphylaxis from foods. Obviously, again, it's different in kids. Kids get a lot of reactions to foods and more frequently get anaphylaxis from foods. So what are kind of risk factors for systemic reactions? First of all, what we all know, most of the people that present with systemic reaction, even with fatal reactions, the majority of these people don't have a known allergy to bee sting before. It can be really your first severe reaction to a bee, could be severe anaphylaxis or even be a fatal reaction. If an adult develops an anaphylactic reaction, then there is a very high risk of developing an anaphylactic reaction again to re-exposure. Studies say between 40 and 60%. And this risk, although it's higher early on after the first bee sting, it can last for a long time. So even 10 years or 20 years after your anaphylactic reaction to a bee sting, your chance of developing another anaphylactic reaction is quite high, 20 to 30%. So it's a severe problem, it's a significant problem, and identifying the people that actually get anaphylaxis to bee stings and doing something about it is important to prevent these severe reactions. So what confers increased risk for systemic reaction? And again, they are not very good studies. It's a rare condition. In many cases, we don't even identify all these patients that have an anaphylactic reaction to bee sting. So kind of studies, observational studies mostly over the year, they've shown that older men, and older, over 40, I'm over 40, so I don't offend anybody else by calling us older men, with cardiovascular disease and a previous history of Hymenoptera, still allergy is the most, they have higher risk than the rest of the population. Use of certain medications that have also increased risk for anaphylaxis. It's the same thing here, we're talking about anaphylaxis. Stings in the head or neck can have more common, more severe symptoms. And the big problem in all these reactions, the same thing that we see also in anaphylaxis, is that delayed or lack of use of adrenaline to treat the symptoms, or epinephrine to treat the symptoms, it's one of the big problems. And I will not talk much about mastocytosis, but mastocytosis is a condition where we have high burden of mast cells, and people's mast cells are very sensitive to activation, seem to get a lot of reactions with bee sting and have more severe reactions. So how do we diagnose it? Like a lot of things in allergy, really, a good history is the most important first step to make a diagnosis. Diagnostic tests are important, but if we don't have a good history and we don't have high level of suspicion when we do the diagnostic test, very often the diagnostic tests we do are not as useful. Classify the reaction. Again, the type of reaction will kind of determine what treatment we'll suggest and where we will go from there. And then we do skin test. So skin test with venoms can identify the particular Hymenoptera that somebody might be sensitive to. So you find venom-specific IgE antibodies. And also can tell us which one is responsible, because most of the patients, when they show up in the clinic, they cannot really tell us what bee they were stung with. And even myself, at least, even when they describe the bee to me, I'm not very good at identifying what kind of bee it was. So these tests can help us kind of identify which bee might be responsible for the symptoms. We can do in vitro tests, so we can measure specific IgE antibodies in the serum with kind of what we generally call rust tests, although most of them are not rust anymore, obviously. But these have their uses, and they could be the next step after we do skin tests, especially if we have a skin test negative person, because there is a small number of people who can pick them up with in vitro tests after they have a negative skin test. One of the problems, and I will not spend too much time because it came up also earlier today when we were talking about diagnosis with recombinant antigens and kind of component result diagnosis, is how do we identify double sensitivities? So somebody comes, had one sting in their life, they had an anaphylactic reaction, we do skin tests and they are positive to two bees, two kinds of bees. Obviously they reacted to one of them, and we really don't know whether they are sensitive to both of them or there is some cross-reaction. There is cases where there is true double sensitization, but there are also cases where there is cross-reaction between either because the allergens are very similar, for example, the hyaluronidases can be very similar, or sometimes there is IG cross-reactive to carbohydrate determinants. So a lot of these allergens in bees have carbohydrates. They are proteins with carbohydrate moieties on them. And some of the Igs against these carbohydrates, and this IG is not actually associated with anaphylactic reactions. And there is also significant cross-reactivity between different kinds of insects. So, for example, the first difference is that across the world, the insects are very different. They might belong to the same family, but they could be different members of the family. Honeybees across the world kind of cross-react a lot, so they are very similar. But there are also similarities between honeybees and bumblebees, or the cross-reactivity between different vespids. So it's important to know all these things and be able to identify what is the specific bee that caused the symptom. And we talked, as I said, we had the talk earlier today about using recombinant antigens that might give us an idea of what's the likelihood that somebody is sensitized to both kinds of bees or one bee. And this was one recent study where they tried to expand a little more and see what's the best option. And when they combined these basophil activation assays with recombinant antigens and also deplete the serum from the carbohydrate specific IG and then measuring IG to recombinant antigens, they found that that's the best way to identify the people that are cross-reactive versus the people that are sensitive to both allergens. Obviously, that's something that we cannot do in general practice these days. I mean, we're probably a long way from doing basophil activation assays as a routine test for the patients because they're not easy assays to do. But it is where the future of this area is probably going, where hopefully one day we'll have better ways to really identify what the specific allergen that somebody is sensitive to. Treatment, again, I mean, there are some kind of basic ideas that we have to follow. Obviously, we have to advise the patient to minimize exposure to further stings. I mean, the best treatment is the prevention. And if we knew that somebody will never get stung with a bee again, then we almost don't have to do anything. But it's impossible, obviously, to decrease the risk to zero, and that's why we need to do also other things. Giving people epinephrine, and I've done that. I have it half the time epinephrine and half adrenaline. So self-administering epinephrine to people, it's very important because it will be the first line treatment if they develop anaphylaxis. And we all know that venom immunotherapy in selected people is the treatment of choice. And we had also in this meeting a couple of discussions about immunotherapy, and there was a big kind of controversy yesterday, if you want that. But I think this area is the one area that there is really no kind of dissenting opinion. I think everybody believes that immunotherapy for bee venom is indicated and is very effective. There are different schedules of immunotherapy, and different people for different reasons use different schedules. For example, during my training, I worked in an army hospital in the US where I did my training, and we used most of the times ultra-rush regimens because we would bring soldiers from wherever unit they were at, keep them for a day in the hospital, do ultra-rush regimen, and then send them back, and thinking that over the next couple of days they will be protected, or very soon they will be protected. Most of the times, at least nowadays in my clinic, I do the conventional regimens. They have lower risk of side effects, but they take longer time to do. It is an effective treatment. Studies with this treatment started quite early, from 78. The first New England Journal of Medicine was in 78. And all the studies show that there is a very high degree of protection. 83 to 95% protection of people that are on immunotherapy in different studies. And the good thing is we heard also for the rest of the immunotherapy. Immunotherapy seems to have immunomodulatory effects, so the effect of immunotherapy remains even after we stop the treatment. And it's clear also in bee venom immunotherapy that the effect is long-lasting after the treatment. You discontinue the treatment. Although the exact duration of how long this thing lasts is not very clear. So just I'll show you, last year there was a Cochrane database meta-analysis of the studies for venom immunotherapy. And they included studies for ant, bee, and wasp immunotherapy in children and adults, people that had a previous systemic or large local reaction. So they went through a lot of papers. They identified around 30 papers, if I remember correctly. There were only 7 papers that they included, and Cochrane databases are kind of restricted sometimes. They want really very high quality studies, and that's a good thing because the data are more valid. But then we end up with very small numbers when we do that because a lot of the other studies around get to be kind of rejected from the study. Most of the studies were rejected because they were not placebo-controlled, and it's very difficult to kind of understand the risk of something if you don't have a placebo group. So most of them were subcutaneous immunotherapy, and that's what we do. There was one study also that included also sublingual immunotherapy for venom. And as the authors say, there was a high risk of bias because a lot of these studies, they were not blinded. So the researchers knew what group the patient was on. So what did the study show? So when they studied any systemic reaction to an insect sting, and studied it either to 6 weeks and up to 4 years after the initiation of immunotherapy, there was significant decrease of the risk. So the relative risk ratio was down to 0.1 with a confidence interval from 0.03 to 0.28. So it really protects from systemic reaction to insect stings. When they also studied large local reaction, there was also a significant protection from large local reactions. Again, relative risk down to about 40%. And also when they studied quality of life, and that was less studies, there were 2 studies that had quality of life, but there was a 1.2 points higher quality of life in people that received immunotherapy versus those that did not receive immunotherapy. Something that in the scale they used is clinically significant. And that's because people are less worried about it. They think they are protected. They know more also what to do in cases that something happens, so they really increase their quality of life. And in this kind of review, they have, in the end, what's interesting, kind of give some ideas of what should be done to really understand how the disease works and improve what we can do about the disease. So we should identify the patient groups who benefit most from the treatment and also the optimal treatment duration. There are some guidelines, there are some ideas of what we should do, but we really don't know what's the best way to do it. There haven't been enough studies. There haven't been studies that have compared different duration of treatment to really know what's the optimal. Also, quality of life and health economics outcomes would be very important. I mean, it's a new thing, and now all the studies these days actually measure these outcomes because we think they are important, both for the patient, if we increase their quality of life, but also for the healthcare system, especially at a time where around the world there are a lot of economic problems, and kind of understanding how much we should spend to improve people's quality of life is important to know if it's worth it. And also future trials should investigate modes of immunotherapy, which carry a reduced risk of systemic reactions. So sublingual immunotherapy, we had today a long talk and discussion about sublingual immunotherapy. It's a very kind of interesting idea. It's not just an idea anymore. It's a very interesting treatment for now. I mean, it has very good data that it works. Although I train in North America, I've never used sublingual immunotherapy, and now that it's approved in Canada for about a year, I'm kind of trying to learn how to use it. But seeing all the studies and all the big experience, long experience that has been in Europe, it's a very interesting idea, and bee venom immunotherapy could be also the next step to use it more regularly. Not a lot of ideas of when the immunotherapy is effective, and I put one study, I will just discuss it very quickly. I mean, we start somebody on immunotherapy, we don't know if they are protected or if they go the right direction until they get a bee sting and we know they are protected or not. So this study, they did whole genome expression. So they got blood, they did microarrays for RNA, so they find all the genes that are transcribed in their blood. And they found that some people, when they start the immunotherapy, they have a lot of changes from before the immunotherapy in this expression. And then if you take people that you stop the immunotherapy and you know they are protected, they also have changes, but they are much less than the people that are on active immunotherapy. So there are some changes that remain long-term, so maybe these changes can be measured early on and maybe they can predict who is protected and who can stop immunotherapy. And studies like that is what we need, I think, to be able to put more evidence behind how long we do immunotherapy, what protocol is the best with immunotherapy, when do we stop it, and all these questions. So what are the predictors of systemic reactions during immunotherapy? So again, that's an observational prospective study, about 608 patients, so a large number of patients for this kind of studies. They measured a lot of things in these patients. So what came out of all this stuff? So therapy with honeybee seems to be more likely to cause systemic reactions than therapy with Vespid. And that, obviously, we treat them with what they are sensitive to, so we don't make this decision. But people that need therapy for honeybee, they are more likely to have side effects, so we have to be more careful. Presence of venom-specific Ig in the serum, so the more of that can increase the risk of developing symptoms. The type of the regimen, as we said, the ultra-rush regimens have higher risk of side effects than the more conventional regimens. The interval between the most recent sting reaction and immunotherapy, so the closer it is to the sting reaction, the more likely to develop severe side effects. And also, the last one that they saw was that basal tryptase level in the serum seemed to be associated also with increased risk of reactions. So they suggested in the paper that maybe it's a good idea to measure tryptase levels on everyone, and maybe we have to be more careful for people that have elevated tryptase levels to begin with. And what's interesting in the tryptase level is that the tryptase level had increased risk only for Vespid immunotherapy, not for honeybee immunotherapy. So again, maybe there are subgroups of patients and there are specific categories where we can understand how these things work and be able to prevent some of these reactions. I will finish with a little thing going back to mast cells and mastocytosis. So we know that mastocytosis is considered a condition that predisposes to severe reaction to insect stings. But it's the other way around also. If somebody has an insect sting reaction, is this a mast cell disease? So there was a study where they got close to 400 subjects with systemic reactions to insect stings, and they measured in all of them basal tryptase levels. And if the tryptase level was high, even though it was not as high to actually trigger directly an evaluation for mastocytosis, they did the classic mastocytosis evaluation. So they did bone marrow biopsies, histology, cytology in the bone marrow biopsy, flow cytometry, and also check these KIT mutations that we know are associated with mastocytosis. So what did they find? So out of the 379 patients, 44 had high tryptase levels. So it's about 10% of the patients that have high tryptase levels. Out of those 44, 31 have anaphylaxis. And out of those 44, they did bone marrow analysis and all the workup in 34 patients. And actually, it's very interesting after that. Out of those 34 patients, 21, actually they were able to diagnose them with indolent systemic mastocytosis. So they had mastocytosis. It was not very severe. It hadn't manifested itself before, but they had the disease. And another 9 had what it's kind of this new entity over the last years, monoclonal mast cell activation syndrome. So condition where there is some disorder in the mast cells, but not enough, but the patient does not fulfill the criteria for systemic mastocytosis. And actually what's even more interesting is that all the subjects that had anaphylaxis, so these 31 patients that had anaphylaxis, all of them were diagnosed with a mast cell disorder. So it almost from this study, if it's true, looks like that if you have an anaphylactic reaction to bee sting, almost we have to look for mast cell disorders, and maybe that's the reason why these patients develop anaphylaxis and the rest of the sensitive people have less severe reactions to bee stings. So in conclusion, insect venom allergy is not an uncommon condition. Appropriate diagnosis and treatment can decrease adverse effect of insect stings and improve patients' quality of life. And as we talked before, it is one of the clear indications for allergen immunotherapy for these patients. Thank you for your attention.